Welcome back to another episode of Psychiatry Rewritten. My name is Lane. A lot of people think the mental health system starts with a therapist, or a diagnosis, or a psych ward. But for thousands of people, it starts with sirens and it ends in a hallway. Let's talk about what actually happens when someone is in a psychiatric emergency. Not the ideal version, not the textbook version, not the pamphlet version, the real version. You call 911 because your child is hallucinating or self-harming, because your partner locked themselves in the bathroom with a bottle of pills or a gun, because your loved one is standing on a bridge. And first responders show up. EMTs, maybe probably the police too. They're doing the best they can, but they're not trained for this, not really. Their job is to stabilize, contain, and then transport. And the only place to take them? The ER. But the ER wasn't built for psychiatry. It was built for trauma, for car crashes, heart attacks, bullet wounds. So what happens when someone shows up not bleeding, but screaming, or silent, or suicidal? They get boarded. That's the term. It means they wait. On a gurney, in a hallway, for hours, oftentimes, for days, even weeks. They're not getting therapy. They're not getting started on meds. They're not getting assessed every hour by a team of specialists. They're just waiting. And if they don't have an advocate, a family member calling every so often, every 4 hours, a social worker pushing for them, someone watching, then the odds of being overlooked skyrocket. People without voices get ignored. Closed mouths don't get fed, is a saying. Or worse, discharged prematurely because they stopped saying they were suicidal. Not because they're safe or because they really feel better, but because they're tired. Why does this happen? Because the system is backwards. Only people with private insurance or Medicaid can access most private psychiatric facilities. And those beds fill up fast. Sometimes with patients who know how to say the right things. Sometimes with people malingering. sometimes with people who just want shelter and safety for a few days, and who have figured out that saying, "I'm hearing voices," might get them in. Meanwhile, the people who are genuinely sick, severely impaired, or actively psychotic often don't have insurance at all, right? Because they're not functioning well enough to maintain coverage. So, where do they go? Well, they're referred to state psychiatric hospitals. But those hospitals, they have wait lists. In many states, up to 40 to 60 people are waiting for a psych bed every single day. In North Carolina, the average wait is 6 days. In Tennessee, some people wait in the ER for 2 weeks, sleeping under fluorescent lights, receiving no structured treatment, often not even a consistent medication regimen. And while they wait, they get worse. Now, add children into the mix, okay? Because pediatric psych emergencies are exploding. During COVID, psychiatric boarding for kids rose 200 to 400% in some states. In one 6-month span, 39% of children who came to the ER with psychiatric needs had to wait over 48 hours for a placement. Some kids, especially those under 12, get admitted to inpatient units early, prematurely, and it creates a cycle. The earlier a child is admitted to an inpatient facility, the more likely they are to become a repeat patient. And that's something that my mom, who was a social worker and a crisis worker who has been for so many years in the emergency department, and it's not because they're manipulative, but because no one ever built the right plan for them outside of crisis. They go in scared, they come out scarred, and then they go back in. And here's the kicker. While all this is happening, patients sit there, hungry, disoriented, often sedated. One patient in Nashville was locked in a room for 4 days with no food, no change of clothes, and no toothbrush. This is not mental health care. This is containment at best. People think the ER is a lifeline, but for psychiatric patients, it's often the first trauma in a long chain of them. I had rent due the day before I got there. I kept telling them that I just needed one call. I could have paid it online if they let me use my phone. But they said I was on a hold. So I sat in the hallway. And someone else sat in my apartment after they changed the locks. I didn't come in screaming. I came in scared. I told them I hadn't slept in 3 days. And the voices were getting louder, and I didn't feel safe with myself. That's what you're supposed to say, right? I was hoping for help. Instead, I got a stretcher right by the door. Plastic blanket. Bright lights. No windows. No meds. No food. They gave me crackers and juice. No bullshit. The guy across from me was detoxing and kept vomiting into a plastic bag on the floor, being disrespectful to the nurses. No curtain. No privacy. Just pain on display. On day 3, a man down the hall started yelling. He wasn't violent. He was hallucinating. Said something about God watching him through the lights. And then security came. 2 guys, big, fast as hell. They slammed him to the ground and pulled his pants down right there in front of all of us. Needle. Bam. In the thigh. He screamed. And I just watched. I watched them drug him in for being afraid. And I thought, this is where I came to feel safer? On day 5, I tried to ask again if I could call my landlord. They said I was still on a 72-hour hold. I said it had already been 5 days. The nurse shrugged. A psychiatrist came once, asked if I was still hearing voices. I said yes, but quieter now, because I stopped telling them what was really happening. I didn't want a needle in my ass too. By the time they discharged me, it had been 8 days. I'd missed rent, lost my apartment. I didn't have meds or a follow-up plan. They gave me a bus pass and a discharge paper that said stable. I walked out with nowhere to go. And all I could think was, if this was supposed to help, what does failing look like? He came in because he was scared of his mind. He left with no home, no meds, and more trauma than he started with. And that story isn't uncommon. And that's not recovery. That's a system swallowing people whole. If someone walked in with a heart attack, we wouldn't say, let's hold them in the hallway until they stop complaining. But with psych, that's basically the protocol. The emergency room was never meant to be the front line of mental health care. It's built for trauma, for bleeding, for triage. But psychiatric emergencies don't bleed. They don't show up on a CT scan. They don't spike your blood pressure in ways the monitor understands. So instead of treatment, patients get containment. Here's what typically happens. The person arrives, often via police or ambulance. Sometimes by private vehicle, the family will bring them in. And then they're placed on some type of psychiatric hold. typically at least until the social worker or somebody can come from the mental health team and evaluate them, right? They're stripped of their belongings, including phones and clothes with drawstrings, just really any of their articles. They're moved into a safe room, which often means no windows, obviously, no stimulation, no privacy. And then they wait. No daily therapy. No trauma-informed de-escalation. Often no medication until a psychiatrist makes a formal recommendation, which can take days. And if the patient is uninsured, they're not going to a private psych hospital. They're going on a wait list for a state facility that may take up to 50, that may be up to 50 patients long. So what happens in the meantime? They sit, they pace, or scream, or shut down. Not to mention the one-to-one sitters that often have to be in place. Hospital employees are required to sit as one-to-one sitters in the doorway. That's what I mean by no privacy. Psychiatric boarding is not treatment, though. Boarding is the term for holding a psychiatric patient in the ER while waiting for a bed. It's supposed to be temporary, but temporary has become indefinite. A study from the American College of Emergency Physicians found that over 70% of ERs regularly board psych patients for more than 24 hours. But many report boarding for 5 to 10 days, especially for those without insurance or those needing child, adolescent, or geriatric care. And then if you include other physical ailments, chronic conditions, even diabetes, it becomes much more complicated trying to find placement. Sometimes impossible. The risk of malingering and misuse. So, psych beds in private hospitals are often taken up by patients who know how to say the right things. Some are homeless and just want a place to sleep. Some are seeking safety from abusive situations or street level danger. Some are seeking a reset or access to medications, but not necessarily because they're in acute psychiatric crisis. And some are intentionally malingering, presenting psychiatric symptoms for secondary gain: food, shelter, detox, court protection, or avoiding jail. Meanwhile, the person in the hallway with real delusions or no insurance and no ability to advocate for themselves, they're stuck in limbo. And certain groups suffer the most. Children are often misunderstood or dismissed as manipulative or attention-seeking. But when they show up in crisis, they're frequently restrained, sedated, or boarded for days with zero child-specific support or developmentally appropriate care. Elderly patients with dementia or delirium may be labeled aggressive, leading to chemical or combative, leading to chemical restraint instead of proper medical evaluation. Non-verbal individuals, including those with developmental disabilities or autism, are often completely misunderstood in the ER. Their fear or confusion is interpreted as agitation or defiance, and they pay for it with forced holds or sedatives. Let's be clear. ER staff are not the villains. Let me say that again. ER staff are not the villains. Most want to help, but they're understaffed, they're not trained in psychiatric care, they don't have dedicated psych liaisons or safe holding environments. There are too few psychiatric beds, and most of them are for patients with insurance. And to just be completely transparent, when there is someone in the next room actively dying, in cardiac arrest, their heart stopped, they're not breathing, and their family is absolutely losing their mind. That's the ER. That's the reality. And then you have the psych patient in the next room. And yes, both are so important. And they are important to everybody in the ER. They are. But you have to prioritize. That's what triage is for. That's why these things exist, and that's what I'm talking about. That's the point why the ER is not, it was not meant for the way that we use it. And the result, the ER becomes a pressure cooker of suffering with no release valve. Discharge notes might say the patient was evaluated and deemed stable. But what that often means is they stopped saying they were suicidal. They were quiet for long enough. Or there were simply no other options. Everybody worked as hard as they could. It's been exhausted. The social worker has exhausted all of their options. The documentation, it looks good. The outcome was anything but. Because we built a system where psychiatric patients can be held for a week without therapy, without medication, without a plan, and then get sent home with a one-line referral and, if they're lucky, a bus pass. That's not mental health care. That's a crisis we've normalized. So let's say it clearly and loudly for those in the back. The emergency room was never supposed to be a psychiatric unit. It became one because no one else would step up. ER nurses are some of the most skilled people in the building. Trust that. They are trained to save lives in seconds. Strokes, trauma codes, crashes, arrests, chaos. That's what they signed up for. And they know that. But psychiatric patients don't bleed out in front of you. Right? They pace. They scream. They dissociate. They argue. They're scared. And they shut down. And there's no stat page for that. And more importantly, there's not enough time for that. No crash cart for psychosis. No life-saving protocol when someone is unraveling quietly. So psych patients end up in the ER because the ER is the only place that has to take them. Let me say that again. Psych patients don't end up in the ER because it's the right place, right? They end up there because it's the only place. And I do mean only, because even the jails will not take them. Unless it is absolutely forced upon them. And that's how the ER became a dumping ground for the systems we refuse to fund. Mental health, housing, addiction treatment, community support. All of it collapsed and landed on the ER's doorstep. And then the corporations showed up, right? Huge healthcare companies, often headquartered states away in places like California or Texas, start opening behavioral health hospitals in small rural towns. Sounds great on paper, right? But here's what actually happens. These hospitals are for profit. They only take private insurance or Medicaid. Their treatment model is often cookie cutter, protocol based, and built for profit margins, right? They don't understand or invest in the community they're operating in. I could mention a name. And when someone in a small rural town is having a psychiatric crisis and doesn't meet their criteria, where do they go? Back to the ER. And if they're uninsured or high risk or nonverbal or autistic or elderly with dementia, they're not accepted anywhere. And the ER is left holding the bag. This isn't a staffing issue. This isn't about bad ERs. This is about the fact that we're dumping society's most vulnerable people into the one system that was never built for them, and then acting shocked when they fall through the cracks. ER staff are burning out. Psych patients are traumatized. And rural hospitals are being bled dry by corporations that don't even live in the same zip code. The ER isn't broken. It's being used wrong. It was built for trauma. But now, it's where we send the people no one else will claim. Psych patients don't need trauma bays. They need care. They need plans. They need structure. They need systems that don't treat them like a burden on the hallway floor. When a child walks into an ER in crisis, they don't need to be restrained. They need to be understood. But that's not what happens. Not in the real world. Let's talk about what happens when it's not an adult in crisis. Let's talk about when it's a child. Because if the ER isn't safe for adults, it's even worse for kids. Picture this. I'm always painting pictures in your minds. A 10-year-old shows up because she's self-harming. Self-harming, cutting. A 13-year-old boy says he wants to die. A nonverbal 9-year-old with autism starts throwing things at school, and no one knows what else to do. So they bring them to the ER. They strip their clothes. They put them in a gown with no shoes, no drawstrings, no dignity, no socks, no phone, no gaming system. They sit them in a locked room with no windows, no clock, no TV for 10, 20, 40 hours, sometimes longer. And when that child starts panicking, sometimes you can't get a hold of their parents, or they don't have parents. They don't have guardians. They aren't around. That's the reality. When they start melting down, though, not because they're violent, but because they're terrified, they get restrained or injected or labeled as dangerous. And just like that, a scared child becomes a behavioral problem. A meltdown becomes aggression. And you can see the cycle begins. And if you're sitting there thinking, oh, this is dramatic, kids always have some guardian, no. If you are thinking like that, then you have it all wrong. Because the reality is never cookie cutter. The statistics we can't ignore. ER boarding for children in psychiatric crisis has doubled or tripled in many states since COVID. Some hospitals report waiting times of over 3 to 5 days for pediatric psych placement. A 2021 survey found that over 40% of ERs have boarded children for more than 48 hours without a psych bed. And the earlier a child is admitted, the more likely they are to be readmitted within 30 days, especially if no effective or just no outpatient plan is built, because we never treated the root. We just treated the moment. And here's what gets missed. Children don't always say, "I'm depressed." They say, "I hate school. I want to die. I don't care anymore." Or they just explode because their nervous system has no other language. And when adults don't recognize that as trauma or overwhelm or neurodivergence, they treat it like defiance or manipulation or a bad kid. So the child gets hospitalized, then discharged, then hospitalized again. And suddenly they're 15 years old with 4 inpatient stays and no one asking what happened before the first one. Like, what we call crisis in kids often starts as a signal that no one knew how to interpret. By the time we respond, we're not de-escalating a child. We're managing the trauma we caused the first time in now an adolescent or an adult. If a 10-year-old is screaming in fear, and the first thing we do is hold them down, then we're not stabilizing. We're sending a message about what it means to be in pain. And that message sticks. Kids don't forget their first time being restrained or sedated or stripped and left to wait in a room alone with no answers, or with someone staring at them, a stranger staring at them from the doorway. That's not crisis care. That's institutional trauma. And we've been calling it psychiatry. It doesn't have to be this way. We keep saying the system is broken. But broken things, they still hold shape. This one's not just broken. It was never built to hold the weight we put on it. Now, we can't talk about psychiatric patients in the ER without talking about what comes next. Because awareness alone does not save lives, unfortunately. So here it is. What actually needs to change? 1. Stop using the ER as a psychiatric holding zone. Emergency rooms were never designed for mental health care. Stop using them as a substitute for actual systems of support. We need dedicated psychiatric crisis centers, mobile response teams, and community-based stabilization units, right? That keep people out of ERs and inpatient hospitals altogether when possible. 2, build more beds, but don't stop there. We do need more psych beds, especially for uninsured, pediatric, geriatric, and neurodivergent populations. But this isn't just about space. It's about what happens in that space, right? Trauma-informed design, humanized care, not corporations just building for profit. Staff who are trained in de-escalation, not just sedation. 3, train first responders and reimagine who responds. Because most mental health calls go to 911. And 911 is sending the police. We need crisis response teams with social workers, peer support specialists, and clinicians, not just law enforcement. Not just the threat of you can go to county or you can go to the ER. Programs like Cahoots in Oregon prove this works. It's not a theory. It's already saving lives. 4, hold corporations accountable. Stop letting giant for-profit hospital systems open behavioral health centers. They don't staff, don't regulate, and don't support. These companies come into rural areas, build inadequate psych units, accept only profitable patients, and dump the rest on local ERs. If you want to profit off the word mental health, you better be ready to serve the people who need it most, buddy. Not just the ones with a PPO card. 5, there's no cap in my rap. Protect kids from institutional trauma. No more stripping 9-year-olds and holding them in rooms with no windows for 3 days. No more sedating kids because we don't have a plan or we don't have time. Unacceptable. Children need developmentally appropriate care, family-based support, and outpatient structures that prevent re-traumatization. Like, do we care or do we not? Number 6, give patients a voice and someone to speak for them. Many psychiatric patients in the ER have no advocate. No, the one-to-one sitter, unfortunately, no. No family member, they have no social worker in-house at all times, no one asking the hard questions. Every hospital should have psychiatric care navigators or peer advocates embedded in their ER departments. Someone trained to say, this isn't working. Let's do better. I have worked, if you can't tell how passionately I feel, I've worked in the ER. I've worked in the rural, local ER on night shift for years that gets dumped on. So I've been on the inside, but I'm also speaking facts. The ER is doing its job. The problem is, we asked it to do everyone else's too. This isn't about blaming nurses or hating hospitals or shaming staff who are just trying to stay afloat. Nay. This is about naming the failure and refusing to let it keep happening in silence. Because no one should come to the ER looking for safety and leave more broken than they arrived. This episode is called First Stop Rock Bottom. You can't stabilize what you refuse to understand. And you can't treat what you keep pushing into the hallway. Or back to triage. So, a little call to action. If you've made it this far, here's what you can do next. If you're a clinician, learn the difference between escalation and dysregulation. Speak up when you see patients being warehoused instead of helped. Ask better questions, always. Advocate. 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 And then advocate some more until they're sick of you. Advocate for better systems. If you're a hospital admin or a policymaker, fund real mental health alternatives. Create protocols that center dignity, not just liability, okay? We're all in this together, and the bigger picture is beautiful if we could just work together. It doesn't have to be a versus. And stop letting for-profit systems pretend that psychiatric care is profitable only when it's neat. If you're a parent, loved one, or survivor, your voice matters. Keep telling these stories. Keep holding the system accountable. Because silence is what keeps this happening. We don't need more sedation. We need more solutions. You saw me in the hallway. Not really, but kind of. You walked past, clipboard in hand. I think you were a nurse or a social worker. You didn't look at me long. Just enough to know I was one of them. Psych hold. Paper gown. Fluorescent eyes. You weren't supposed to know my name. I wasn't violent. I wasn't loud. I was just stuck. Day 4, I stopped asking what time it was. Day 5, I forgot the sound of silence. Because someone down the hall was always screaming. Day 6, I stopped eating. Day 7, I gave the right answers. And day 8, they let me go. No plan, no meds, just a discharge summary with typos and a cab voucher. They did pay for my cab. That was nice. The ER saved my vitals, but not my story. And honestly, that might have mattered more. The ER isn't the beginning of healing. But for many, it's where the story starts. We owe them a better first chapter. Thank you for listening. We'll see you next time.